All right, here we are in lecture 3 of the cervical pathologies. And in this one, we are going to be looking at neuropathies as well as fracture and instability. So let's dive right on in. So neuropathies in general, we're going to diagnose neuropathies as some sort of pathology affecting the neurologic system or the nervous system, right? In the musculoskeletal world, and in this class specifically, I'm going to break it into 3 main things we're going to be talking about or looking at or classifications, right? One is going to be myelopathy. Myelopathy, I'm going to define as damage to the spinal cord and or brainstem, but that's something to do with the central nervous system. That's something I don't like, and I certainly don't want to come across, and I don't want to treat, right? That's something I want to refer out and get some help with, right? Radiculopathy is going to be some sort of neurologic pathology at the nerve root specifically. And then peripheral neuropathy is going to be some sort of pathologic process affecting the nerve anywhere beyond distal to the nerve root, right? So your peripheral nerves. In general, symptoms surrounding neuropathies or things patients might say which would make me think, uh-oh, sounds like neuropathy or damage to neurologic tissue, would be any form of numbness, full-blown numbness, like I cannot feel anything, right? Tingling, so paresthesia, pins and needles type feeling, or this feeling of like ants crawling on your skin, right? Weakness, muscle weakness, right? You maybe weakness, specifically weakness without pain, like I can't lift my arm up. This one I can, this one I can't, right? Any sort of balance or coordination or function loss, right? Those to me start saying, ooh, I wonder if we're dealing with nerve problems, right? Or sometimes different descriptors of the pain sensations they're feeling, like burning or electrical or zinging, zapping type of pain. That to me starts to say, or I start to lean a little more towards wondering about nerves and nerve stuff, right? How do you develop neuropathy? Well, it's multifactorial. A lot of things could lead to problems with neuropathy in general, or lead to neuropathy in general, right? So general metabolic conditions, degenerative conditions, trauma, direct pressures, inflammatory conditions, all these could lead to problems with the neurologic system. And that's not it. There's more, right? How do you diagnose neuropathies? A good way to do it is imaging. That's a good one, right? Depending on where you suspect it and what you suspect is creating the neuropathy, might uh, decide what it might lead toward image you want to get. MRIs, if we're looking like brain or central canal type stuff, right? If we're looking peripheral neuropathies, we're largely looking at maybe doing some sort of nerve conduction test, like this picture here. Or if we're looking at radiculopathies, maybe we're doing something as simple as an X-ray to see if there's bony encroachment along where a nerve root might be coming out. So it depends, but imaging is potentially a good way to go. Possibly even musculoskeletal ultrasounds is not a bad way to go, right? Orthopedic testing, another way you could go. Not my favorite. I'm not a huge fan on orthopedic tests, even though I'm tasked to teach you guys this stuff. Um, but it is an option. You know, upper limb tension tests, as is sort of demonstrated here. Well, I think this is actually a nerve flossing routine, but it's very similar to upper limb tension test. I think is a great way to put stress on nerves specifically, and there's certain compression tests which are fairly reliable when bundled together, right? How do you treat neuropathies? Oh, well, what's your goal? What's your goal, right? Usually, as I say right here, it depends on the severity and the source of the neuropathy. Like, if it's a very severe nerve degeneration, like, I can't do a whole lot for that, right? If we're dealing with like a cancer, a tumor pushing on a nerve, you're like, well, I don't know if I can help with that, right? Not conservatively and certainly not manually. Maybe I can help with some of the pain, but I'm not going to reverse this process, right? But if I'm dealing with like a peripheral neuropathy, something like carpal tunnel syndrome, peroneal artery syndrome, thoracic outlet syndrome, even different forms of radiculopathy, yeah, I can absolutely help with that. There's a biomechanical component that I feel educated enough to understand to at least educate my patient with, right? If not directly relieve some of these exacerbating factors, right? How do I accomplish this? Well, I'm going to use a lot of this stuff But the first and foremost, I think the big one is education. The patient has to understand what neuropathy is and why they're feeling this. Because frequently they're not feeling it at the location. They're feeling it somewhere else. So they don't understand why you're having them do certain neck exercises when the pain is in their hand, right? So I think there's a large educational component with this sort of stuff. But if it is something I'm going to treat, yeah, I'm going to use a lot of manual therapies. I think they work really, really well, right? That usually blended with machines. Topical meds, now we can maybe operate some of the pain gate theories there. And internal meds if you really need it, right? Some sort of nerve suppressant. And then there's always the referral to a neurologist. If you're nervous or you're seeing a progression or worsening of the neuropathy, yeah, go get a specialist to take a look, right? So let's look at diagnosing or the symptoms that might present with myelopathy, radiculopathy, peripheral neuropathy broadly, right? So in general, myelopathy, we're going to be looking at damage to spinal cord, brainstem, that sort of thing. So they're going to come in and talk about their neurologic type symptoms bilaterally, right? Bilaterally. When I hear bilateral, or when they're explaining how both their hands are going numb, I don't like that, right? If it is something that is musculoskeletal, right, it's probably going to be more within the spinal cord, and that's not something I really want to manage alone, at least, right? If there's facial involvement, not a big fan of that, right? Like if half their face is down here and can't lift or whatever, or numb, or they start losing weird vision or weird hearing problems, like those tend to be more cranial nerves, and cranial nerves come off the brainstem. So in a manual therapy practice, these aren't things I like to hear, right? General balance and coordination issues, like a fast loss of this stuff. Ooh, don't like that. Sounds neurologic, sounds progressive, sounds like myelopathy, right? So I'm going for images pretty quick on this sort of thing, and then I'm going for neurologist referrals, excuse me, right? Radiculopathies. Okay, now we're in the ballpark, right? Radiculopathies, problems to nerve roots. Okay, a lot of times that's going to be some sort of musculoskeletal complaint, something I could probably work with here, right? So what you're generally going to see is those neurologic complaints, numbness, tingling, weakness, right, within a dermatomal pattern, because they're generally affecting a nerve root. Nerve roots have very specific muscular associations as well as sensory distribution patches peripherally. So if you know your dermatomes and you know your muscle maps, right, it becomes relatively easy during an MRS testing, a motor reflex sensory testing, to isolate what nerve root you think it is. And then there are different orthopedic tests that will also help with radiculopathies, different sorts of compression tests, right? And then the last one, peripheral neuropathies. So numbness, tingling, weakness, neurologic type symptoms within the course of a peripheral nerve, right? Instead of a dermatome, right? A lot of this stuff, if it's not metabolic or some sort of weird infection or something like that, is going to be generally going to be some sort of compression from muscle or activity, right? Maybe clothing in some extreme cases, right? But that's going to be like, oh, you're holding a position where this muscle is contracting and pinching this nerve long enough to create an irritation, right? Or repetitively enough to start to irritate it, right? So these generally respond to manual therapies very, very well. Right, so distribution is a big one, right? So like the C6 dermatome, right, along the lateral side of the hand, is going to also that's going to be like a multi what am I trying to say here, right? The median nerve, excuse me, like the median nerve is going to cover more than the C6 dermatome alone, right? It's going to cover some of the middle finger, some of C7 and C6, right? So you're going to get a multi-dermatomal pattern when we're dealing with the median nerve versus, right, uh, just the median. Oh boy, what am I trying to say here? Peripheral nerves and dermatome sensory patches are different, is ultimately what I'm trying to say, right? So if you're getting the distribution within a peripheral nerve, I'm going to lean more towards peripheral neuropathy. I'm getting a dermatome, I'm going to lean more towards radiculopathy. Oof, that was a rough one. Okay, so let's look at cervical radiculopathy, so nerve root problem right in here, right? Realistically, a lot of times it should be called radiculitis because usually it's more of an acute irritation to it, but a radiculopathy would be more of a chronic or constant uh, irritation to that area. So sometimes called a pinched nerve, but it's generally irritation to a specific nerve root, either mechanical, a direct pinch, or some sort of chemical irritation, local inflammation from, say, a disc herniation or an extreme facet syndrome, or tears to local little rotatory muscles around this area might create enough of an inflammatory response in that area, right? So symptoms: dermatomal, radiation of numbness, tingling, weakness, burning pain, right? Sometimes limitation in neck motions, and sometimes local neck pain as well. So result of a lot of times inflammation. If there's inflammation in that area from, say, like I said before, disc herniation, right? Maybe it's just some of the annular tearing along that disc is enough to incite an inflammatory response, and boom, we have an irritation on that nerve root, right? I think more commonly what people think is, even though I think local inflammation is probably going to be the more common form of radiculopathy, but generally people think, oh, it's a direct pinch. That's usually a pretty extreme disc herniation to get to that point, but could happen and does happen, right? So these annular fibers tear the nucleus pulposus, the innards of that disc, pooch out and squish right on that nerve root, pinching it, creating a symptom in a dermatomal pattern, right? Those are going to be typically present in a younger population because younger populations tend to be, so these are gross overviews, broad strokes here, so no one's allowed to get offended, right? Generally, younger populations tend to be more active. They tend to have larger, more hydrated discs, right? So it's a combination of having a bigger disc with a more active lifestyle tends to tear more. Now, does that mean an older population can't get a disc herniation? No, absolutely not. They certainly have their share of disc herniations as well for different reasons, right? But usually disc herniations tend to hit a younger population, whereas bony encroachment, spondylosis, right, some sort of arthritic change, some bony development, typically shows up in an older population, an osteophyte, right? This little bump projecting into the intervertebral foramen where that nerve root is coming out. That's usually going to be in an older population. These kind of degenerative changes take time. They're usually a result of chronic injury and inflammation, right? Just from having your neck for 60 years, right? You've dinged it up enough times that you got to show a little wear and tear in there, right? And that little booger right in there is starting to irritate that nerve root, just like this little booger is squishing out over here. So generally speaking, older populations are going to be more of osteoarthritis or disc bone encroachments, right? Lateral canal stenosis. So how are you going to diagnose these? Well, orthopedic testing is one way to do it, right? Imaging. If you suspect an older population, generally when the symptoms worsen with extension or lateral flexion to that side, because we are squishing down that intervertebral foramen with those little bony growths, right? I'm going to shoot for an X-ray because you get a little lateral, not a lateral view, a little 3/4 turn on an X-ray, and you get a view of that IVF, and you see those bones sticking in there. It's a pretty safe bet that's where it's coming from. If I have a younger population, typically when the symptoms are worse with flexion, right? Because as I flex forward, the disc herniation tends to pooch backwards, or lateral flexion away from the side, disc herniation tends to pooch out that way, right? I'm going to opt for an MRI. I'm going to need to see what the soft tissue looks like, and see how much of a disc herniation we're dealing with, right? So treatment, what is the goal? Well, there's totally different goals for totally different pathologies. Remember, the radiculopathy is almost like the presenting symptom from the disc herniation or the inflammation or the bone growth or whatever it is. It could be causing this. So unless you can tell me what is causing the radiculopathy, I don't have a good answer for you other than like, yeah, I want to relieve the exacerbating factors, right? Does it hurt when you do that? Yeah, don't do that. I mean, that's about what I can tell you, right? Some sort of nerve support and pain management. But I really have to know what's causing it to give you a good answer here, right? So if it is a disc herniation, I'm going to rely heavily on patient education. Well, on all of them. Once again, it's a neuropathy, and anytime there's a neuropathy, I strongly think an educational component is very, very important here, right? But we're going to make a go at manual therapies and exercise therapies if the patient wants to do it, because anything that, less invasive to more invasive, right? Because then the next step up is going to be some sort of surgical fix. Hopefully it's small, but in some cases they end up fusing elements of your neck together. And then you're going to physical therapy after that. So you might as well try some of the exercise therapies before to see if we can get results, right? Whereas if we're dealing with bony changes, well, I'm going to have to educate you a whole lot, but there's nothing I can do externally to make that bone go away. So ultimately, that is a surgical fix if it's needed. But if I can educate you on your lifestyle and what you're dealing with, maybe we can make better choices together to eliminate the movements that cause this problem, right? So really, I'm also going to keep a neurologist or an orthosurgeon pretty close by for some of these kind of things. Okay. The next thing I'm going to talk quickly about is cervical fractures. I don't have a whole lot to say about cervical fractures. So some sort of break of the cervical spine. There's a lot of different ways to do it. Here's a great little article on the most most common breaks of the neck, right? You can just go ahead and click that link or type it in if you're watching this and you don't have the notes or whatever, right? But basically, it's damage to the osseous structures. This is probably always going to be a result of trauma. In fact, if it's not a result of trauma, I'm scared, right? Because that would be some sort of pathologic fracture from some sort of lytic lesion, which is like metastasis or some horrible thing like that, right? So generally, there's going to be a trauma, there's going to be a sharp pain, maybe a sense of instability, maybe a sense of neurologic, or not even a sense, neurologic deficit or some sort of loss of function, right? This has the potential to be very, very dangerous, or it has the potential to be very stable and annoying, right? Depending on the type and where the fracture is, right? You're going to need some sort of diagnostic to really make sure you know what you're dealing with, all the way up to an MRI. Maybe you can see it on an X-ray, depending on what's present, right? If it's a stable fracture, right, when we're dealing with treatment, it depends on the severity. If it's stable, then really we're dealing with some sort of strengthening around the area, right? A slow, gradual increase of stress to the area and then using the muscles to help strengthen it, right? If there's any sort of neurologic compromise, you're going to the ER, right? You have to go right away. After you get stabilized in the ER, they'll probably put you in some sort of halo brace like this for a long period of time, right? But when someone's in a halo brace, there are other things you can do. Yeah, I mean, you can help with circulation, right? And maybe we're doing with nutrients, reducing stress, that sort of thing, education, right? Because when we're dealing with cervical fractures, the big thing we're looking for, besides direct trauma to the spinal cord, which could ultimately lead to death, right, or quadriplegia or something awful like that, is a form of instability, right? Some sort of specifically upper cervical instability. So this is a sideline view. Here's a great little video to watch if you want to freak yourself out on a video fluoroscopy of upper cervical instability. It kind of weaves me out every time I watch it, right? But on a flexion extension X-ray study, you might measure the difference of the space available for the cord, the SAC, with an extension view and then a flexion view, and see if that space diminishes because the dens is squeaking back against that spinal cord, right? And then also suddenly we have a presence of an atlantodens interspace over here, which shouldn't be there. That should be stable. So this might not even be a fracture. This could be a severe sprain, right? So ligamentous or osseous damage, right? So this is the specific instability we're talking about here is atlantoaxial instability. So it's damage to the way up high structures, right? So neck pain, limited range of motion, and then we have unpredictable neurologic symptoms reproduced by neck movement. Myelopathy, remember that's how I diagnosed or define myelopathies. Facial, weird, unpredictable, bilateral, weird stuff that happens in a neurologic way as opposed to a dermatome, right? Or peripheral nerve. Now we're having like, ooh, this half of my face is tingling and then this eye is gone and I can't swallow when I look up or look down. You're like, oh God, get out of here, right? I'm going to tape you to the wall until the paramedics come. So trauma. One-time high force, motor vehicle accidents, sports, something like that, repetitive low forces, right, building up over time, right? There are certain conditions, rheumatoid arthritis, Down syndrome, Ehlers-Danlos, Marfan's, that make people at higher risk for upper cervical instability, right? So depending on the cause, right, and depending on a surgical consult, right, I will ultimately, the treatment I'm going to do for this is stabilization, right? Until we can start really building up the strength of the neck, via all sorts of different like head hangs or just sort of like banding exercises. Oh, I love this. This is like a YouTube video waiting, a fail YouTube video waiting to happen. Just smack, right? If we don't have that strength yet, we're going to start with bracing, right? As we start to build up the strength within the collar, and then we're going to start building up muscle strength around there. So once again, education is going to be a huge, huge component for this sort of thing. But this is not a common thing. I would think an occupational therapist, maybe some physical therapy to offices might see this thing. I occasionally see some sort of instability. If I do, it's a very stable. Seems like an oxymoron, a stable instability, but an instability associated with rheumatoid arthritis or Ehlers-Danlos or something like that, where it's a known instability, but it's not severe. So we can do different sorts of therapies to help strengthen the neck, right? But yeah, the big one is there neurologic compromise or signs of neurologic compromise, or were they in some sort of immediate high trauma uh, event, in which case they should be going to the ER with a neck stabilization on them. So anyway, there you go.